And, one of the things that I think is important to realize about Parkinson's disease is that Parkinson's disease is a systemic disorder. And I'm going to apologize. Give me 1 minute. I want to make sure my fellow is seeing the other patient. So hold on one sec.
Excellent. You and I were talking about that the other day, Brian, how the emotional side, mental side, cognitive side, and the hallucinations and delusions side of things can be devastating.
Sorry about that.
Even more than some other things.
All right, sorry about that. So just wanted to make sure everybody was tucked in. What I was saying is, one of the things that I think is important to realize about Parkinson's disease, particularly for patients to have this insight, is that Parkinson's is really a systemic disorder. So what do I mean by that? What I mean by that is that every single organ system in the body is affected by Parkinson's disease. And so if you look at, if you think about all of the different aspects that Parkinson's disease affects, it affects your ability to urinate, constipation, swallowing, sleeping. It can affect mood. It can affect a patient's mood. So there are multiple organ systems that are affected in Parkinson's disease. It's not just a disorder of movement. And so there are really two reasons that happens. So one is it affects a part of the nervous system called the autonomic nervous system. So that's the part of the nervous system that operates in the background. We don't typically think about it. It's it's the part of the nervous system. So for example, if somebody had a sandwich for lunch, that sandwich is being digested and the nutrients are being absorbed, but we're not actively thinking about it. All of that is sort of happening automatically, hence the name autonomic nervous system. But it's really the brain that does that without us really thinking about it. And that part of the nervous system is affected very early in Parkinson's disease. And one of the things that part of the nervous system controls is our blood pressure. So when patients with Parkinson's disease stand up, oftentimes their blood pressure will drop. And the problem with that is it can lead to lots of fatigue, being tired, but it can also lead to falls. And the reason it's particularly important in our discussion is that a lot of the medications and we'll talk about the medicines in a few minutes, but a lot of the medications that we used to use to treat hallucinations and delusions drop blood pressure. And so it's important when we're picking a medication to understand what some of the side effects of that medicine are and how that in particular affects Parkinson's patients, knowing that the autonomic nervous system is affected in Parkinson's disease. The other reason that Parkinson's disease is a systemic disorder is that it affects multiple neurotransmitters in the brain. So neurotransmitters, one way to sort of think about neurotransmitters is that they're little chemicals within the brain that allow one part of the brain to talk to another part of the brain. And so one of those, there are lots of neurotransmitters in the brain. There's acetylcholine, serotonin, glutamate, pretty much any major neurotransmitter system that you can think of is involved in Parkinson's disease. But one in particular, serotonin, is affected very early in Parkinson's disease. And so we're going to talk a little bit about serotonin today and how it plays a role in hallucinations and delusions. We typically think of serotonin as playing a role in mood disorders, so anxiety and depression, but we're going to talk a little bit about how it plays a role in hallucinations and delusions today. So with that, we're going to move forward. So these are the UK Brain Bank criteria for Parkinson's disease. These are the motor criteria that we look for to make a diagnosis of Parkinson's disease. So you need slowness of movement. So that's one of the main symptoms, one of the main motor symptoms of Parkinson's disease. And then some people will have tremors, some will have stiffness. And later on in the disease, you can get balance problems. So those are considered the UK Brain Bank criteria. They're primarily used to make the diagnosis of Parkinson's disease. But there are lots of aspects of Parkinson's disease that have a lot more to do with some of the non-motor symptoms that we talked about earlier. So depression, anxiety, urinary issues, sleep disturbances. But one of the non-motor symptoms can be hallucinations and delusions, and we'll talk a little bit about that. So hallucinations are when you see something that isn't there, or the cousin of a hallucination is an illusion. An illusion is where there's a stimulus there. So for example, there's a pen here, but my brain misinterprets it as a stick. So that would be an example of an illusion. A very common illusion that patients will sometimes describe is seeing a pattern on a tile and thinking, or seeing a little dirt on the floor and thinking that maybe that's a spider or an insect. So that would be an example of an illusion. A hallucination is seeing, seeing a child sitting in a chair when there's nobody there. So those are sort of examples. Delusions, and delusions are important to keep in mind, because delusions sometimes are more problematic than the hallucination. And a delusion is thinking something is happening that isn't actually occurring. So, and one of the most important things to remember about a delusion is that it's not amenable to reason. So if somebody's having a delusion, you cannot reason with them. So I'll give you examples of some very common delusions. There's this delusion that somebody is trying to come into the house, or somebody's trying to hurt a patient, or that the medicine that a patient is receiving is poison. So that's a very common delusion that patients will sometimes have. Another very common delusion might be that the spouse is cheating on them. And so that's another very common delusion. And again, it's important to remember that a delusion is not open to reason. You can't reason with somebody who's having a delusion. There are internal and external. Yeah.
Hey, Doc, before we get into, I know, hallucinations and delusions, they're pretty strong words. And I know that there's black and white definitions in that, but usually when we're dealing with Parkinson's disease, it's really not that black and white. It's finding out why someone may not be eating their full meal, why someone doesn't want to go outside or has some anxiety from doing things. They intertwine with other things, would you say? Am I correct?
They do. They affect lots of things. So I'll give you a few examples. A few years ago, I had a patient who every time he went down the stairs, he would end up falling. And remember, falls are a major issue for Parkinson's patients. It's one of the leading causes of having patients go to the hospital. And so every time he would go down the stairs, he would fall. And the reason was that he was seeing a puddle at the bottom of the stairs that he was trying to avoid. Now, that puddle wasn't actually there, but this is something that he would see. And so he would try and avoid the puddle and he would end up falling. If you sort of think about it, if you think that your wife is cheating on you, that's going to cause a lot of psychological angst. It's going to cause a lot of anxiety. It can affect somebody's ability to be taken care of. So if you think that your caregiver is giving you poison every time they tell you to take your Sinemet and you refuse to take your medicine, your Parkinson's symptoms are going to be a lot worse. So those are just some of the ways how delusions and hallucinations can have a very real impact on patients. Is that what you were asking me about, Brian?
Yeah, because I think when we think of hallucinations, delusions, we don't think that it could be really happening, and it just looks very unreal in that stage. But I think they mask themselves in other areas, whether you gave a good example how one of your patients were cooking a meal for 4, and it made sense that she thought the grandkids were coming over, or the husband thought the grandparents were coming over. And when they were talking about the conversation, he just assumed it was the grandchildren, but it wasn't the grandchildren at all. She saw 2 children that she invited into the house to eat. So, those tricky things how they can mask themselves.
And that also brings up another point, and that is that one of the things we know just like Parkinson's disease is a progressive disorder, right? The motor symptoms over time will get worse and they need to be treated. Hallucinations and delusions are the same way. They will progress over time. And Brian reminded me of a patient of mine who I often talk about, but that in her hallucinations started off as seeing little children. And her grandchildren lived far away, so the little children were almost like a substitute for her grandkids. And it was very pleasurable for her to see these children in their apartment every night. And early on, it wasn't so much of an issue. But as the disease progressed, she started cooking a meal for these kids every night. And now there were just the two of them in the apartment, but she was making a meal for 10 people. And so that's the part where you have to remember that it may start off as a very sort of innocuous or something that doesn't really bother the patient very much, doesn't really bother the caregiver very much, but over time it will progress. And one of the other things to remember is that this is not something you want to wait to treat until it's an emergency, because when it's an emergency, patients in the hospital, they're delusional or hallucinating, fighting with the staff, in restraints. That's not the time to treat this. The time to treat this is before that happens, when patients have a say in what happens to them and how they're treated. So, it's important to remember that we have good treatments for this, and the earlier we treat this, the more successful the treatment will be. And the less, the fewer medications that will be needed to treat it. So typically, the longer somebody waits to treat this, those are the patients that require 2 or 3 different medications to control the psychosis. So the earlier we treat it, the better somebody is going to do. So let me very quickly talk about internal and external causes. So internal causes are things we don't have a lot of control over. What stage of the disease? Is there a prior history of mental health disorders, vision problems? External causes are things that we do have some control over, medications, alcohol, drug use, the light level. So simply raising the light level can make a big difference. And that's one of the things that we do before we try medications is some of the conservative therapies. So talking to your loved one, reorientation, what time of day it is, where they are, who you are. And then in the evening times, raising the level of the light in the home can be very helpful in controlling some of these hallucinations and delusions. But over time, again, remember what I said, over time it will progress, and most patients will require medication to treat this. And so one of the other things that I think is important, remember, hallucinations and delusions will get worse over time, but it's a slow process. Just like Parkinson's disease slowly progresses, typically over years, not months or weeks. So if there's a sudden change, if suddenly somebody who doesn't have any hallucinations and delusions develops them, or there's a sudden increase in the severity of the hallucinations and delusions. So typically in that scenario, there's something outside of the brain affecting the brain, and that something is typically an infection or an electrolyte abnormality. And so you always want to make sure that you tell your doctor if there's a sudden change, because what they may do is just order some blood work. So checking the blood for any electrolyte abnormalities, dehydration, infection, and then checking the urine to make sure there's no infection there. So, and that's called a metabolic encephalopathy. Again, the name doesn't matter so much. The concept does, and the main point here is if there is a sudden change, you always want to let your physician know, and typically they'll order some blood work and some urine testing. So we've sort of talked about, so this is an illusion. The problem here is that the sock looks like a mouse. Hallucinations can come in many different forms. The most common one is visual, seeing things, but you can have auditory hallucinations. Some patients will hear music. You can have tactile hallucinations, so touch. So I've had patients tell me that they feel like somebody is touching them. I recently saw a patient who felt that their husband who had passed away many years ago was touching them on the back. So you can have tactile hallucinations. They can come in many forms, but again, visual hallucinations are the most common. What's the problem here? Obviously, the problem is that there are no children there, but he's seeing a reflection of the children in the water. And again, sometimes this is how hallucinations start. And eventually the children won't just be a reflection, they'll actually be standing there next to him. Delusions, we've talked about a little bit already. Again, jealousy delusions are very common, particularly in men. Persecutory delusions, somebody's trying to get me. The medicine that they're giving me is poison. I don't want to take it. Very common delusions that we see in our patients. What's the problem there? He thinks somebody is trying to come into the house, right? So that's a delusion where he thinks somebody's trying to come get him. We've talked about progression already. We're going to keep moving. So this is important. There's a myth out there that hallucinations and delusions always basically go together with dementia. So somebody has to have memory problems and cognitive issues, and then you see the hallucinations and delusions. And that's not the case. There are lots of patients where they may have hallucinations and delusions, but not have any cognitive issues. So that's important to remember. The other point here is that it's important to separate dreams from when somebody is awake. There's a very common symptom in Parkinson's disease called Rem Behavior Disorder, so acting out of dreams. And that is, it's very common. It's one of the earliest symptoms of Parkinson's disease, but that is not a hallucination. Hallucinations happen when somebody is completely awake and they're seeing something. Acting out of a dream or having a very vivid or lifelike dream, that's not a hallucination. It's important to make the distinction because the treatments are very different between the two of them. Rem behavior disorder, acting out of dreams, typically is treated with clonazepam. Hallucinations are typically treated with antipsychotics. So let's see here. One of the statistics that you'll oftentimes see is that about 50% of Parkinson's patients at some point during the course of their illness will have to deal with this. It's important to remember that this is also one of the leading causes of why patients end up having to leave their home. And the other piece of that is that most patients are reluctant to bring this up to their doctor. And then the flip side is most doctors are reluctant to bring it up with their patients. And so you have an illness that 50% of PD patients will have to deal with, a symptom that 50% of Parkinson's patients will have to deal with. It's one of the leading causes of patients having to leave their home, and nobody wants to talk about it. So it really is incumbent on patients and their caregivers to bring this up if it's happening. And the reason you want to bring it up is that since 2016, we actually have good treatments for this, right? So we talked about this already. We're going to keep moving forward. So this, I really like this slide, and the main point here is that this is a team approach. The caregiver and the patient and then the healthcare provider are all important parts of this team. And a lot of times the caregiver can provide insight that the patient may not be able to provide. So it's important to keep that in mind. The other things that I would add to this would be physical therapists. Exercise is incredibly important for Parkinson's patients, not just for the physical well-being, but also for the mental well-being. So let's talk about the treatments for Parkinson's disease. So prior to 2016, we didn't have very good treatments for Parkinson's disease, and for Parkinson's disease psychosis. And in fact, all of the treatments that we had for PD psychosis were medications that had been studied and used in schizophrenia patients. So what's the biggest difference between schizophrenia patients and Parkinson's patients? And the obvious answer there to me is their age. Right? So prior to 2016, all of the antipsychotics that we used to treat Parkinson's disease psychosis were studied in schizophrenia patients. And so we were using medications that were designed for patients in their 30s, 40s, and 50s to treat patients in their 60s, 70s, and 80s. And there's an inherent problem there because somebody in their 50s is not the same person as somebody in their 70s or 80s. And Nuplazid or pimavanserin is the first and the only medication that's specifically designed to treat Parkinson's, specifically designed to treat hallucinations and delusions in Parkinson's disease patients. The average age of the patient in these studies was 72 years old. So much more reflective of the patients that we actually treat than some of the other medications that we used to use. So Nuplazid or pimavanserin does come with a black box warning. Every antipsychotic currently available in the United States comes with a black box warning, but Nuplazid has a little bit of a modification. So I'll read you the first bullet point, which is true of every antipsychotic currently available. So medicines like Nuplazid can raise the risk of death in elderly people who have lost touch with reality, psychosis due to confusion and memory loss or dementia. So essentially, the risk of death in somebody with dementia increases if you treat them with an atypical antipsychotic or a typical antipsychotic. Here's the modification for Nuplazid. So the FDA sort of realized that Nuplazid works in a little bit different way than all of the other antipsychotics. And so the modification is that Nuplazid is not approved for the treatment of patients with dementia-related psychosis unrelated to the hallucinations and delusions associated with Parkinson's disease psychosis. So essentially what the FDA is saying is that if somebody has Parkinson's disease and they have psychosis, regardless of whether they have dementia or not, it is okay to use this medication in that group of patients, okay? How does Nuplazid work? So I think it's important for patients to know how their medications work. And so all of the other antipsychotics that came before pimavanserin worked on dopamine. The way they controlled psychosis was by blocking dopamine. The problem in a Parkinson's patient is that if you block dopamine in a Parkinson's patient, somebody who's not making enough dopamine to begin with, the risk is that you're going to significantly increase their motor symptoms, the walking, the stiffness, the tremor, the balance problems, right? So if you block the dopamine, what little dopamine that there is available, their symptoms are going to get dramatically worse. Nuplazid is really the first antipsychotic that doesn't work on the dopamine system. It doesn't touch the dopaminergic system at all, and it primarily works on the serotonergic system. So it blocks one particular serotonin receptor, and that's the way it controls psychosis. And so what that means is it doesn't affect the motor symptoms of Parkinson's disease. It doesn't make them worse because it doesn't affect the dopamine receptor. Okay. So in the clinical study, so there was the pivotal study or the main study that was done that led to the approval of Nuplazid. It was what they were able to show in that study was that there was a statistically significant reduction in the occurrence of hallucinations and delusions in patients with Parkinson's disease. And again, the average age of the patients in that study was 72 years old. And so what they did was they took a group of patients, and the patients didn't know who was getting the active drug, and the physicians who were prescribing the medication didn't know who was getting the active drug. And half the patients were randomly assigned to get placebo or sugar pills, and the other half was assigned to get Nuplazid. And then at the end of the study, they looked and determined who got the active drug, who got placebo, and who had an improvement in their hallucinations and delusions. And what they were able to show very clearly is that the Nuplazid group had a statistically significant improvement over the sugar pills or placebo. The average, so it took one of the things to remember about pimavanserin is that it doesn't work right away. It takes about 6 to 8 weeks to work. So when you get this medicine, it's important to realize that you have to be patient. Give it some time to work. I typically tell patients about 2 months. And not every patient will respond to Nuplazid, but in the studies, if I'm remembering this correctly, about 65% of patients had a meaningful, clinically meaningful reduction in their hallucinations and delusions. Okay. Again, I mentioned this earlier, but the key point here is there was no worsening in their motor symptoms. And again, the reason is it didn't bind to dopamine like all of the other atypical antipsychotics that came before it. You don't need, it doesn't interact with any of the medications that are typically used to treat Parkinson's disease, including carbidopa, levodopa, so you don't need to adjust any dosages of the other medications. Here's the side effect profile. The main things that I always tell my patients is that in about seven out of 100 people, you can see some swelling. If you stop the drug, it'll go away. So if that happens, it's important to bring it up to your physician. And then feeling confused or having an increase in the hallucinations, that can also sometimes happen. So if that happens, you do want to bring that up with your physician. And the main point to remember there is that this won't be just a subtle change. This will be an obvious change. If you have something called QTC prolongation, or you know that you're on a medication that also prolongs QTC interval, please let your doctor know. QTC is a measure of within the EKG of your heart rhythm. So if that's an issue, let your physician know. One other thing, it is pimavanserin is hepatically cleared, so it's cleared by the liver. So if you have any liver issues, please let your physician know that. And as is true of any medication, you always want to tell your doctor all of the medications that you're taking. It is easy to take. It's once a day, one 34 milligram tablet once a day. And that's pretty much it. In terms of cost, I'll let Brian say a few words about this, but the main thing I want to mention is that from what I understand, the cost to somebody on Medicare shouldn't be more than $20 to $30 a month. Correct, Brian?
Yeah, that's correct. The average cost is less than $20 a month for patients, and that could be there could be help out there with foundations.
Yeah. So I'm going to stop there in the interest of time, and I'll open it up to any questions if there are any.
Thank you, doctor. That's really great information. And yeah, please, people who are watching, if you have any questions, please type them in the comments or the chat box here on Zoom.
Hey, Doc, I got a quick question, two quick questions. So you talk about these hallucinations. How long do you think it typically takes a patient or a caregiver to bring them up to their physicians? Is it something that you ask, or what advice would you give to like caregivers or patients to doing so?
Yes. So, in my practice, I always ask about this. This is something I screen for at every visit because I know it's very, very common. But what I also know is that a lot of physicians won't bring this up. And from a caregiver perspective and from a patient perspective, most patients and most caregivers don't bring this up. And there's this reluctance to talk about it. We sort of tend not to talk about the elephant in the room. And so the advice I would give to caregivers and patients is that if this is happening, don't wait until it's a major problem. Bring it up early, because remember that the time to treat this is early, before it's become a problem. Because if you wait until it's a problem, it's much, much harder to treat. And that's when patients end up going to the emergency room. And what happens in the emergency room is that a lot of times these patients will be given a medication called Haldol or Risperdal, which does block dopamine. And all of a sudden, their Parkinson's symptoms get dramatically worse. So again, much better to treat this early before it becomes a major problem.
I love that you're speaking like this, doctor, because I work as rehabilitation here with many, many people with Parkinson's. And one of the things we find is that, with all due respect to the neurology community, these questions are not asked. This topic is not brought up a lot of the times. And I think it can be really one of the more debilitating things. This can maybe negatively affect movement maybe more than their actual lack of balance. And it can, hallucinations, delusions. I have a gentleman right now I see who sees the troops outside of his window. They're going to come and attack him. And there are no troops, of course. But this is great information. I do have one question from a friend of mine, Laura. Laura says, thank you for the information. It's very interesting. Is it more common? Is this, like delusions and things, more common when a patient presents with depression or not necessarily?
Yes, it is. So any prior history of depression or anxiety or any mental health disorder increases your risk of having this. So it is more common in patients who have a prior history of depression or anxiety. And what you were saying, this oftentimes is far more problematic for patients and their quality of life than the tremor or the stiffness or any of the motor symptoms. You're exactly right in that. And you're absolutely right. We don't ask about it. And yet it's one of the most debilitating symptoms. And it's the leading cause of patients leaving their home and going to a facility.
Is there any relation, also from Laura, any relation with vivid dreams? Like if someone has more vivid dreams, are they more likely to have delusions, let's say?
Oftentimes, vivid dreams are the precursor to having hallucinations and delusions. So yes, there does seem to be a correlation.
Okay, thank you. Thank you. Any other questions from anybody out there?
Yeah, Doc, how would you say that this first starts? Is it different with people, or does it tend to say like, I know that false sense of presence comes up a lot. Can you define what that is and how one may experience that?
Yeah, so false sense of presence is this sense that somebody is sitting or standing next to you. And usually patients realize that there's nobody there, right? But the way and that certainly does happen. We do see patients with that. What I typically see in my patients is that this will start off very innocently. The lampshade changes colors, or the lampshade the design or the pattern on the lampshade changes, and that's all it is initially. And maybe that doesn't necessarily need to be treated, but you want to follow that person very closely, because what I know for a fact is that it will get worse over time and it's going to need to be treated. And so, the other thing that I see very commonly is they're looking at a carpet and there's a pattern on the carpet and it'll start to shimmer or move, or they'll see an insect where there isn't one. Hold on one second.
She did.
Super interesting.
I'll be right there.
Okay.
Give me 2 minutes. Thanks, Dan. So sometimes they may see that, but that's typically how it starts, sort of very innocuously, and then it'll slowly progress from there.
Okay. All right. Okay. My next question would be, can a patient have Parkinson's and dementia, and would that be a good, would Nuplazid be appropriate?
Yes. So there are lots of patients with Parkinson's disease that do happen to have dementia as well, and also have hallucinations and delusions. And you can certainly use Nuplazid in that group of patients. One of the things to remember about Parkinson's disease psychosis is dementia is not a prerequisite. You don't need to have dementia to have hallucinations and delusions. But if you happen to have dementia and hallucinations and delusions, it's perfectly okay to still use Nuplazid. Okay.
Just one more question. Do you have time for one more question?
Yep, go ahead.
Okay, thank you so much. Actually, it's 3 questions, but in kind of one. What percentage of your patients are prescribed Nuplazid? Besides the medication, what else should a person with PD be doing? And like what kind of therapy? That's it.
So I can't give you an exact percentage of my patients that are prescribed Nuplazid. What I can tell you is I probably write at least 2 to 3 prescriptions every week And so it is my first line therapy for PD psychosis. It's the medication that I use the most and use first when I see somebody with hallucinations and delusions. And I've been using it since 2016, and I've had a good experience with it. I've had good tolerability, few side effects, and good benefit. In terms of what sorts of therapy, so what I tell patients is that you want to take care of your mind and you want to take care of your body, and the two are interrelated. Your physical therapy is going to help with your mind and it's going to help with your body, and your cognitive, doing something that keeps you cognitively engaged and stimulated, is going to help with your mind and it's going to help with your body. So both sides of the equation matter.
Perfect. Thank you.
Okay.
Thank you so much. Any other questions? I just want to, Laura says, thank you. Excellent presentation. Doctor, thanks so much for joining us. It's really a pleasure to have you.
Thank you for having me. It was a pleasure. And Brian, thank you for putting this together.
Thank you, Doc. Have a great day.
Take care. Bye-bye.
Take care.
Bye.
So, Brian, we can move on here. I have a few slides to share when you're ready. No hurry. But anything you want to talk about prior to me doing this?
No, just a review of Dr. Amjad's presentation. Hallucinations and delusions are something that we need to express more and talk about, whether it's with your physical therapy, your primary care doctor, your movement specialist, or any neurologist that you see. It's important that it's treated. I will add that this time of year, it may happen more often because of the serotonin and how the sunlight affects that. So as the sun goes down earlier, we may see more of these hallucinations and delusions throughout our loved ones. So it's just important that we talk about it, that we document it, and that the doctor is aware of it. I think what Dr. Amjad said, that is treating it earlier is probably one of the best ways to deal with it. We know that exercise helps, and we know that sunlight helps. So, living up here in the Northeast, we know that it's going to get darker and darker as earlier and earlier. So, let's get out there and try to be active, and let's try to eat healthy, and let's just have a better relationship with our caregivers.
Absolutely. I couldn't agree more. Well, if you're ready, I'll move forward with a very quick presentation.
Yeah.
Okay, so before we do this, I just want to just say first that what Dr. Amjad was saying is how the mind, cognitive and body mind is interconnected. So we need to be exercising everything we can, our body and our brain. So let me go into sharing my screen. It's been a little while since I've done this, so here we go. Okay, can you see my screen now? Do you see a screen? Yes. Okay, yeah. Good.
Yes.
All right, I'm just going to go right into I hope it's not wrong for me to do this. I'm going to say I wrote a program and a book. They're both called Parkinson's Regeneration Training. If you want information on this, just send me a message. But we also have information here. Anyone in the area locally, New Plaza, we give it out pretty much every day. And of course, where I'm at here, the doctor here is going to start using it too after you met with him. So it's really great. So the Parkinson's Regeneration Training name came up with the idea of regenerating an improved quality of life. All right, so let's just go through some things. I'm just going to do one quick disclaimer, if you will. The methodology that I use or we use is intended to complement medical care and medications, but not to replace them. All right, we need our neurologists, we need our medical community, and there's a good chance we need our medications, right? As a matter of fact, you're going to learn in a little bit how exercise can help to assimilate medications more effectively, get them in the body faster, and have a longer lasting effect in many cases. So a lot of our education is based on research and evidence, but Some of it's not, because we have to look outside the box. So with that, let's move forward. All right, so my goal has always been to take this arrow in the middle, and the arrow actually would represent a gap. On the left side of the gap is our current, let's say, level of knowledge and accessibility, let's say, to medical care, neurology care, physical therapy, education, and to how much we have. And I've been in countries where there's almost no education and very little care available. But we want to take that and go to the right side of the arrow, and we want to fill this arrow with education research so that on the right side, we're improving functional life for a person living with Parkinson's disease, okay? This is really for anybody, anyone interested, people with PD, fitness professionals, doctors, physios, caregivers, everyone. All right, so we're gonna blast you with a bunch of bullet points here. We wanna help the PD with Parkinson's to live a full and active life, as full and active as they possibly can. We know that Parkinson's is a full body multifunction experience. And I got that right directly from World Parkinson Congress 2016, Portland, Oregon. Huge event out there, World Parkinson's Congress. So we want to improve quality of life, slow disease progression, reduce fall risk. As Dr. Amjad said, that's our #1 concern, right? We want to positively impact cognition, movement, quality of life, and delay disease onset if someone's predisposed to, let's say, having Parkinson's or Alzheimer's. We want to use our techniques to help people who have it and delay the onset for people who might be prone to getting it. Again, higher risk of falling in the Parkinson's community. And not to scare anyone out there, but the #1 cause of mortality in the Parkinson's population are complications from a fall, not the fall itself necessarily. Imagine that you're having a delusion that something's in front of you that's not there, and you end up tripping over something that's actually not there. And things like this have actually happened. I know of one case where a gentleman fell down during delusion. This is in Toronto. Dr. Alfonso Fasano was the one who told me this story. Fell down, banged his head, went to the hospital. A month later, he died of pneumonia. So it wasn't the fall, it was the complications. So we want to keep people upright. Walk is our most functional movement of the day. And so we want to walk well so that we can avoid falling. Well, one thing we know for sure, especially when you look at the work of Dr. John Rady, who's a best-selling author and also a professor at Harvard, movement lights up the brain. So if you just get moving, in fact, Rady says that the part of the body that probably benefits more than any other part of the body from exercise is the brain. Even if you're not doing any cognition or memory stuff, movement generates activity in the brain. That image is supposed to represent neurons that are having, let's say, synaptical firing patterns that help them to wire together. Okay. Another way to enhance brain health and immune system and peripheral nervous system and central nervous system, and basically everything, is a holistic approach talked about by John Rady and many others. Where if we can gamify a lot of what we do, if I was to show you the clinic here that I have, you'll see that we actually have some kids games we use, but we're adults, yet we're moving and thinking. So we're gamifying, we're playing. We make it fun. We really try to have fun. I mean, why not? If you can and it's beneficial, right? So move, try to gamify it. If you can, do it outdoors, because the outdoors has all these great negative ions. Plus, you could get all the science of visual stimulation, especially when you're watching like far away into the horizon. There are actually some really good benefits to the brain that way. Music can be another factor, or rhythm and music combined with movement. Okay. Another thing too, I want to say is when you're moving, playing, well, hopefully you're playing probably with another person. So if you move outdoors with another person and maybe you have some music. And the last thing on here, move around barefoot every day. if you want to know the science behind that, just send me a note and I can send you a video to a lecture on it. However, let me just say that 10, 15, 20 minutes, first thing in the morning, walking around barefoot, it's going to stimulate your nervous systems and your brain. And it's a great way to increase brain activity. Okay, so moving forward, we know that the brain has all this circuitry going on, right? And in Parkinson's, we know that sometimes these circuits are, well, no pun intended, short-circuited, because we have not only the substantia nigra, which is losing brain cells and they're dying, but also the nigra striatal. I might have a slide on this, I actually can't remember. But there are other areas that are affected as well, because the dopamine pathways aren't firing up efficiently. All right, so these neural circuitry can be interrupted. So, well, we know that through neuroplasticity, we can actually retrain the brain, give it new circuits to help us regain abilities to do things that we have not been able to do as well as we used to. All right, so I'll just do the second part here. You've probably heard of neuroplasticity. This is the brain's ability to reorganize and create new neural pathways to adapt to whatever as it needs. Now, there's something I want to make a really important distinction in here in a minute. Before I do that, though, how many people here have ever ridden a bicycle? Probably most of us. My question is, were you good at it the first time you got on? No, I wasn't. I fell down and my knees were bloody and all that kind of stuff. But I practiced, and then the neural firing patterns, synapses were happening, and it caused the growth of these brain cells together into these circuits. So I now have my bicycle riding pattern circuitry, which is pretty much hardwired in now. And so I ride, and then I get my driver's license, and I decide driving cars way cooler, so I don't ride a bike for 2, 3, 4 years. Well, when I got back on the bicycle, did I have to relearn? No, I just was a little rusty for a couple minutes, and then those circuits had gone kind of quiet, but I wake them up, fire them up, there they are. They're still there, all right? So this is my example of the brain wires together. And it will stay that way in most cases for a very long time, these circuits of abilities that we teach ourselves to do. Okay, so we'll do a lot of multitasking things like having people move while they're doing cognition. I just want to get right. Frequent and repetitive training to develop a new ability or skill will cause the formation of these firing patterns. All right, so through the regular training, these firing patterns are reinforced. And the more solid these connections are in the neurons, in the circuitry we're building, the better we can perform these new skills. All right, so the distinction I really want to make sure we get across today, because this is not talked about very much, and it's very, very important to understand that in young people, for example, I have 2 granddaughters, okay? They're just ripe with neuroplasticity because one is 4.5 months and one is 10 months. And I'm watching these girls learn things. They don't know they're learning anything, but under the age of 25, which maybe explains why we go to school, high school, and try to get college out of the way, and maybe even a master's degree before we're 25, those are the years when most of us will learn most easily. Okay, so the exposure alone can just prompt the creation of new neural circuitry. I'm gonna typo in there. All right, so, you know, babies learn to do all kinds of things just by the exposure to whatever it is, you know, talking, that's a really good one, right? And the brain will customize itself based on experiences. Okay, so that's so easily done when we're younger, but over the age 25, you know, approximately, this changes. The brain is not as neuroplastic. It's not as plastic, not as moldable. So we have to do a 2-step process. This is not rocket science, anyone. But think about this for a minute. If you took the term from Dr. Andrew Huberman that he coined, he has an amazing podcast too, by the way, from the Huberman lab at Stanford. He termed it self-directed adaptive plasticity. So we direct the changes in our brain by implementing two primary steps. And here they are. First is extreme focusing. All right, we're going to focus on what it is we're trying to learn. Maybe it's 1 minute of focus. Maybe it's 10 minutes. Maybe it's 90 minutes. But whatever it is, we want to laser in and then really just try to max out with hyper focus. Get rid of distractions, put the phone away, whatever it is, if that's what it requires. Focus is step number one. And here's why. I want you to understand the science behind it because it's important. When you focus, and you've probably all been through this, noradrenaline is released during periods of focus. And of course, we've all gone through that. But here's the part you may have experienced is when you're focusing, when you're trying to learn a new skill, language, movement, strain, you might feel strain. Okay, so strain or discomfort might be felt during the effort. Well, that's acetylcholine. Okay, it's noradrenaline, and it's going to cause you some fatigue. So then you take a break. But if we don't have this focused effort, we're not going to learn as well. So we want to hyper focus. Right, I'm learning Spanish. I'm getting pretty good at it too. I was on a call just shortly ago, speaking all Spanish. It's so cool. I love talking Spanish. I'm not fluent, but I'm getting much closer. Right, so it's really cool. But I have to focus on every word or every phrase now, not so much every word. And I feel the strain. Well, that's acetylcholine. It's released in the synapses involved that are involved in what it is you're putting the effort towards. Whatever neurons are firing up during a movement, a language, a learning thing, well, those are being marked with acetylcholine, and the acetylcholine actually helps to strengthen them. Okay, so that's just, if you just take all that and just ditch everything I said, because it's complicated maybe, although I don't think it's too complicated. Just know that focus is step one, extreme focus. And if that's hard for you, maybe you want to think about attaching a reward to the focus, like, okay, this is really difficult and I'm jumping these hurdles and I'm doing this and that over here, training with Karl and all that. But this is me getting better. This is me developing a new skill. This is me reducing my chance of falling. Okay, this is me getting better. That can be the reward to help give that carrot at the end of the exercise to get you through the focus. All right, step two though, sleep. Sleep-like state, but sleep is the best. I'm lucky. I'm a very good sleeper. If somebody paid me to sleep, I'd be a multimillionaire. I can sleep anywhere at any time. A lot of people don't sleep well. So that's another topic, but sleep is the answer because during sleep, this is when neural pathways and circuitry are best strengthened. Okay, they're formed and strengthened during sleep after your focus during the exercise that day. I want to add to this, and I should put this in the slide, it's not in there. It doesn't mean if you practice something today a lot and focus, that you're going to be proficient at it tomorrow. It might mean you practice it every day for 3, 4, 5 days or 2 weeks. And all of a sudden, though, it will happen. The repetition of firing those patterns and developing those, getting those synapses going. Okay, and then sleeping. Eventually, you ever had it happen where you wake up and you're just like, oh, okay, now I know this? Well, that's what happened. Okay, the strengthening happening after enough sleep. Maybe it's a few nights. All right, so it's super easy. Focus, sleep, focus, sleep. Just remember that. All right. So one of the things we'll do to help improve movement, though, and dual tasking abilities, multitasking, because a lot of times multitaskings are let's say the cause or the catalyst for a fall. We want to train motor skills, things like memory, various domains of cognition at the same time. So we move and we do cognitive at the same time in an effort to improve movement stability, functionality, and to help reduce or eliminate falls. Let's go through some various types of cognition here. There are many domains of cognition. I'm just going to hit primary 4, I would say. There are, to my knowledge, at this point, I've studied 13 different types of memory. Okay, there's all kinds of different memory. They fall within the cognitive domain, and there's a lot of overlapping. But bottom line is, let's use an example, direct recall. So I have you maybe, you know, walking sideways, cross-footed through hurdles or an agility ladder. And I say, okay, you know, let's say the alphabet backwards. Some people just nail it, right? Let's spell some words. Let's play a game, you know, name all the states you can think of, or I name a state, you name the capital of the state, and then spell it, okay? Maybe I'm counting from 0 to 100 or whatever by sevens. Okay, name every kind of a kitchen appliance you can think of, or things like that, right? That's direct recall. Spatial would be, okay, you're doing some exercise, you're moving, and say, okay, well, you know, tell me how to get from here to your neurologist's office. And give me all the details. Okay, well, I get in my car, I pull out the parking lot, I turn left on Nush, Tennessee, I go to the first light, I turn right on Knoll Road, and I go down, and like that. So now we have spatial awareness. And the advantages of that over, not over direct, but in addition to direct recall, is it fires up circuitry in a different way when we're thinking in terms of space versus recalling things that we should probably know the answers to. Then there's decision making. Simple would be like, I have mitts here where you hold a mitt here and you've got boxing gloves on. I say, you know, right, left, right, left. And then I have like yellow tape on one and green on the other. And I say, you know, yellow, boom, green, boom. Or I say, we do opposites. Like whatever I say, you have to do the opposite. I say hit right, you hit left. I say hit green, you hit yellow. So that's decision making. We can also incorporate that as reactive training a lot of times. How fast can react? We have so many tools we use for this, like these lights that blink up different colors, and I can set them up. You may have seen, well, I'm going to introduce a friend right now, just real quick. Emily Goki is with me. She helps me and comes up very often with some really, really great ideas, don't you? Yeah, she's got great creative ideas. Brian knows Emily. And so we work together to help people, and yeah, come over and see. So Emily's here. She helps me a lot. What are some of the other things? What did you do the other day? We had something that we have a ball with letters on it, the entire alphabet.
Occupations.
Oh yeah, so it's got the alphabet on it.
Subject.
And then we're like passing it back and forth while somebody's like doing some movement. And she comes up with the idea, okay, well, let's, whatever letter you see when you get the ball, name an occupation that starts with a letter.
Mm-hmm.
Right. Today I had K with Bernie and I couldn't think of any K things.
I had K yesterday, I think.
Yeah, I still can't think of any. Me cerebral no function. Things like that. I would get the ball, do a city or a street name around here, or something related to TV shows, movies, actors, actresses. You can pick any subject you want, right?
Yeah,
it's
you
cool.
said one a couple minutes ago that I thought was good. I don't remember what it was.
I don't either. Gotta work on my memory.
Yeah.
So that would be a decision-making kind of thing, or well, actually the ball thing is more direct recall, but you got, so with that, you've got hand-eye coordination during a movement and thinking. So you got a triple, right? 3 things going on. All right. Problem solving is another one. So I kind of have this dream in this clinic of setting up some obstacles where people have to decide, am I going to go over it, under it, around it, or through it? It'd be kind of like a parkour situation. I've taught at the parkour gym in London, I don't know, probably 7 or 8 times. And it's amazing because we had parkour for Parkinson's in London and everybody loved it. You know, you see parkour athletes jumping from one building to another. You don't have to do that to do parkour, but it involves a combination of spatial, getting to the other side of an object, and also decision making. I have to decide what space, what pathway I'll use. And it's really like, we need to get some of that here.
Maybe the poles.
Yeah.
Start the bars.
So that is, here's some cognitive examples. If you want the slideshow, let me know and I'll email it to you. Otherwise, this will be posted on YouTube and various places. So you just go back and look at this stuff and get some ideas, direct recall ideas, spatial awareness ideas, decision-making ideas. I only have a couple more slides. I want to talk real quickly though about exercise, the benefits of getting the heart rate elevated. Okay, why is this so important? In fact, it's the #1 best known way via exercise to slow disease progression is getting your heart rate elevated. Okay, well, why? Okay, we get blood and oxygen to the brain, but that would be for any of us, right? Well, we also have, when we elevate our heart rate for, depends on who you talk to, Stony Brook says 20 minutes minimum, at the equivalent intensity of walking as fast as possible. Okay, so you can hold on a conversation, but walk, like that intensity. You can still talk and walk, but you're walking fast. 20 minutes of that or more is better if you can. There are other things you can do. If somebody can't walk, we can have them throw the virtual reality Oculus on them and they're boxing, and I mean, they'll get their heart rate up. But when the heart rate gets elevated at that approximate intensity for that long, there is an amazing growth hormone called brain-derived neurotrophic factor, BDNF. So on the left, you'll see if we're not exercising and we're not creating brain-derived neurotrophic factor, we can have increased depression and stress, and we're having less neuron activity, we're having less activity, whereas on the right side, we have an enriched environment. Okay, it can be exercise, that's the best way to get BDNF, but also we just have mental stimulation, social interactions. If you like coffee, drink a cup of coffee. That'll actually give you a little bit of BDNF. It's not going to stop your disease, but exercise is the best way though, okay? Because it also creates other hormones and other things which act as an antidepressant, let's say, and achieve neurogenesis, healthier brain, survival of cells. It helps BDNF as it circulates. It's created in the brain, it circulates in the brain, and it helps to maintain cellular structure in the brain and slow down the death by dying brain cells. And there's research that shows that it can give birth to new brain cells in two areas, hippocampus and olfactory bulb, which is sense of smell related. So BDNF is called miracle grow for the brain because of this. All right, I cannot express enough how important it is. When you have BDNF created, we know that it helps keep chemicals in the system longer. This would include medications, and there's a better chance of uptake of those medications, getting into the system faster and having a longer lasting effect. Again, we can help to prevent cell death and promote long-term maintenance and health so that disease does not progress as quickly. And I have, a little disclaimer, because I'm not saying we can stop the disease. We can likely slow progression and improve quality of life. So there's a couple other things I'd like to talk about. Yes, I'm going to leave this on there just in case you decide you want to go buy this. I have a nonprofit foundation. All proceeds from book sales go to Parkinson's Global Project nonprofit. We donate a lot of money every month to people around the world who are with Parkinson's, who are in dire need of assistance and treatments and medications, and in some cases even food. Vibration is a great way to help. We just got a vibrating platform in here after a long drive on Saturday, like 500 something miles round trip, but it's totally worth it because vibration therapy can be so good for so many different reasons. And there's a lot more I could talk about, but check out our website, parkinsonsregenerationtraining.com. I think that's it. For my slideshow, that's it. Brian, I'm here. How you doing, man? The slideshow is complete.
You're muted.
I think you're muted, my friend.
Yeah.
Yes,
There.
I'm here. I'm outside my car. I'm here. Things look very good. Very, very good presentation all over. I appreciate everything. And let's see if people reach out for questions. Let's help one another, and let's help this disease and their loved ones, come an end to it one day. That's my wish.
Absolutely. Are there any questions from anybody? I don't see any questions in Zoom. I've got this running on my business page on Facebook. If you have questions on Facebook, just type them in the comments box. We'll hang around for a minute or two or longer. If we get questions, we're happy to answer them. You know, a great example of somebody who really fights back against the disease is our friend Laura, who's watching. I mean, you know, she's out running. I was in Oaxaca, Mexico with her and a bunch of people in May, maybe, or April. The girl can outrun me. You know, she'll out exercise me. So bravo to you, Laura. You're kicking my butt. There's a lot of people who kick my butt who have Parkinson's. So it's a great way, though, eating right, using your brain, using your body, keep learning, keep moving, eat right, eat well, drink your water, drink enough water. Maybe we can delay the onset. Maybe we can avoid it and other potential problems too. No questions? Brian, anything you want to share?
Nope. Together we can make a difference. So let's keep together and let's just keep fighting the good fight. Thank you all. Thank you very, very much for what you do. I appreciate it.
And play ping pong.
Yes, and we will talk. I will talk to you soon. Thank you.
Well, thank you, Brian, for all you do, because you've been so supportive of my work for so long, and you're doing great work. Appreciate your friendship and your support. Thank you, everybody, for watching. Hope you enjoyed it, and the link's available later. If you want it, just let me know, and I'll send it to you. It will be on YouTube. Thanks, brother. Oh, so he's gone. We're not gone. Any last words of wisdom before we sign off?
Oh boy.
She didn't know I was going to call on her for this.
Not that I can think of. I think you pretty much covered it.
You see how it goes, though, right? You see how this works firsthand with me. You've been around with me a lot doing this stuff, and we can just have a conversation now because it's my Zoom channel. But it's great because, you know, we see people who like the movements, and look at, like, I won't use last names. Look at Janice. Look what she's doing.
Yeah.
Oh my gosh, you know. And when she wasn't doing it for like 2 or 3 weeks, of course, some of that's because I was gone, her movement got worse. Well, it can get better relatively quickly.
That's getting better.
So now that Brian's gone, I can't take you on a tour, but I'll just show you. We have a little clinic here. Okay. Showing a reversed image, but that's okay. So we've got Skelly, our friend. Here's Skelly the skeleton. But over there, you can't really see. You can't really see it. But we have a total body vibrating platform, which we just started using, and that's been really cool.
I can go run out there.
No, that's okay. You can't really see it, but over near the corner is the triple trampoline, the Alpha Champs lateral rebound trainer. We can use it to bound around, or we can also use it for balance and coordination and strength. Of course, we have our hurdles. I have a lot more, just only have a few set up now. We have you're not going to be able to see the Neurotrack, no biggie. We have treadmill, stationary bike, elliptical, the speed bag, the heavy bag, the kickboxing bag. We got our little CT Max with letters, which are interchangeable. I got the whole alphabet and a bunch of numbers. Have people like create, you know, words out of the letters that are on the thing, and then have them move. Sometimes we'll have them move a certain way. Maybe it's rotations, or if they can jump, we have them jump, or some people can do single leg jumping. That's an elastic battle rope by Stroops there, which we can use for a lot of things. So we also have a lot of games, like cognition type of things, puzzles, games, and a little library here with books now. So about 40 books in there. A lot of them are about the brain, movement, and nutrition. And I think that's really all I have to say, but I appreciate everybody tuning in. Janine, thank you. Oh, Janine, oh my gosh, how are you? My God, I haven't seen you since Long Island, and that's going on 3 years this December. We got to talk sometime. I need to pick your brain. So good to see you, Janine. Wow, great, thank you. All right, folks, we're done. All right, Janine, we'll be in touch. Laura, everyone will be in touch. Thank you, everyone. Have a great day. Thanks on Facebook for watching too. Over and out, folks. Keep moving, keep thinking, and eat well and drink water. Bye-bye.